Welcome to this lecture on subarachnoid hemorrhage. My name is Raj Dar. I'm a professor of neurology and a neurointensivist at Washington University in St. Louis. Subarachnoid hemorrhage is a classic neurocritical care disorder and exemplifies many aspects of acute brain injury from the acute and the delayed complications that affect both the body and the brain. In this talk, we will cover how to recognize common types of brain injury, how to organize them, how they present, and specifically talk about subarachnoid hemorrhage, its causes, what are the priorities in working it up, and in the early and subacute management of patients with subarachnoid hemorrhage. We will also specifically talk about delayed cerebral ischemia, a typical complication of SAH, and how management can take that into account. When bleeding occurs in the brain, it can be classified in a number of ways. One is by cause, and another is by location or compartment. Causes of brain bleeds can be traumatic or spontaneous, that occur without any clear inciting event. Another useful way to define and organize brain bleeds are by location or compartment. Here you see various compartments of the brain and where bleeding can occur. The most superficial type of bleeding occurs in the epidural space. These are epidural hematomas, typically arterial bleeding associated with trauma. These are lens-shaped and usually require surgery and can lead to severe acute deterioration. On the left of the brain here, you see a subdural hematoma. These are usually venous bleeding. They can be traumatic or spontaneous. They're typically acute, subacute, or even chronic, and they may or may not require surgery. Then we have bleeding within the brain itself. Here we have intraparenchymal bleeding that can be deep in the brain, here in the basal ganglia. And these present more like a stroke with sudden neurological deficits like paralysis or trouble speaking. Intraparenchymal hemorrhages can also be on the surface of the brain or lobar. Here you see a lobar bleed due to amyloid angiopathy. And these bleeds can also be associated with subarachnoid hemorrhage, which is bleeding on the surface of the brain in the meninges. And here you see an example of a much more diffuse subarachnoid hemorrhage where blood is spread throughout the base of the brain. Now, subarachnoid hemorrhage, as we'll discuss, is different from other types of stroke because it's more diffuse as the blood fills the entire meningeal space. And the causes are different because it implies bleeding from a proximal source where the arteries run within the subarachnoid space, and when blood happens, it spreads more diffusely. And so it presents like a severe generalized brain injury rather than a stroke. So how does subarachnoid hemorrhage present? Well, typically it presents in otherwise healthy people with a sudden severe headache. Often this is described as the worst headache of the person's life, and typically it's sudden and severe at onset, or so-called thunderclap headache. It may be associated with loss of consciousness or a loss of strength, because what's happening is there is blood at an arterial pressure reaching the brain and causing the intracranial pressure to rise suddenly, dramatically, and the blood flow to the brain can actually stop for a matter of seconds or longer. So in this case, we have a healthy woman who falls with a sudden headache, and there are other signs of increased intracranial pressure or bleeding, such as vomiting. Patients may have onset during exertion, and they may have a history of so-called sentinel headaches, which are headaches that are severe but resolve in the days prior to the major event. Subarachnoid hemorrhage is more likely in smokers and more common in women. Now, another symptom that's fairly common in subarachnoid hemorrhage and other neurological diseases is blurred vision. And I'd like to spend a few minutes describing how we can evaluate someone complaining of blurred vision, for example, in this setting. So the first question to ask is, when someone says they have blurred vision, is it really blurred in one eye or both eyes, or is there double vision? And if you can get a sense that there is double vision, you want to ask, is that coming just from one eye, or is it so-called binocular? And binocular diplopia is much more common, and how you define that is if you cover one eye, the double vision goes away, so it requires both the eyes to generate it, and that's usually from an imbalance of the eye movement or the cranial nerves. The other questions to ask when evaluating double vision is, are the eyes aligned? And which direction, when the patient looks to the left or the right or up, is the double vision worse? And which direction is it better? The other thing to be evaluated is what is the position of the eyes in primary position. Are they aligned? Is one eye out or in or down? And also, what's the pupil size? The presence of a dilated pupil and droopy eyes or ptosis can be also a sign that the third nerve is involved. And that's one of the common causes of double vision. And so how do we assess double vision? Well, one way is to look at the eye movements. And so we can take, as I said, the primary position and see if the eyes are aligned or if there's a divergence. And then we want to assess gaze in all cardinal directions: left, right, left and up, left and down, the other way up and down, and then directly up and directly down. And so what you see in this image is that the left eye, first of all, has a droopy eyelid, and when it's able to look to the left, but when the other eye is looking to the right, this left eye is not able, and that's over here. You see that the eye is staying in position. If anything, it's down and out. And that's typical of a third nerve palsy, because what the third nerve does is it moves the eye in all these directions. And that's why you see in this image. But what it doesn't do is it doesn't move, and I'm referring to this eye here, it doesn't move the eye in this direction or in this direction. So when you have a third nerve palsy, many of your eye movements are affected, but you'll have preserved lateral gaze, so the left eye is able to look outward, and the eye may be down and it may be in because the outward down movement is preserved with the fourth nerve. So looking at the eyes in each gaze can tell you which cranial nerve is affected. The other thing to ask the patient who has double vision is whether the two images are side by side or vertically separated or otherwise. This can also help you. For example, with a sixth nerve palsy, where the limitation is only looking to the left, for example, the double vision will be worse looking to the left, and the two images will be separated horizontally with no vertical separation. So that can also be helpful. So why is the third nerve affected in this patient who has a subarachnoid hemorrhage, or a brain aneurysm in this case? And that's because of the proximity of the third nerve, which comes out of the midbrain, as shown over here, coming down around the brainstem, and the circle of Willis. The circle of Willis I'll come back to is where the arteries of the brain run, and you have a blood vessel and a little aneurysm here that we'll show in more detail next. And if that aneurysm ruptures, it can press on the third nerve, and because the third nerve controls all the eye movements, also controls eye opening and the pupil, those features can cause double vision, droopy eyes, and blurred vision. And here you see in more detail a close-up of how the third nerve is running near the internal carotid artery, where the PCOM, or the posterior communicating artery, comes off. And so an aneurysm in that location, as is shown here, can cause compression of the third nerve. The other thing when someone has blurry vision, especially in the setting of a brain injury, such as subarachnoid hemorrhage, is to look inside the eye, especially if you're not seeing another cause of blurred vision, and it's not double vision. And here you see a classic example of retinal hemorrhages, multiple hemorrhages, and in the setting of a brain injury, this is called Terson syndrome. When you have hemorrhages in one or both eyes, they tend to be beneath the retina, and they tend to have this gravity kind of fluid level shape, as you see over here, but they can also be smaller intraretinal hemorrhages. So that's something to look for in patients with subarachnoid hemorrhage. So how do we diagnose subarachnoid hemorrhage? Well, if someone presents within 6 hours, relatively acutely after the onset of headache, loss of consciousness, a non-contrast CT, as shown here, can have a very high sensitivity, 95% or greater, to show bleeding inside the brain, and can diagnose or rule out the presence of brain bleeding. However, if someone presents more than 6 hours after onset of symptoms, or there's a very high suspicion and the CT is negative based on loss of consciousness, vomiting, neurological deficits, such as a third nerve palsy, or retinal hemorrhages, further testing should be done. And typically, beyond 6 hours, you will see discoloration of the spinal fluid. And so a lumbar puncture should be performed looking for xanthochromia, which means a yellow coloration of the spinal fluid when it's spun down. And that's basically the presence of blood cells causing bilirubin in your spinal fluid. And that can be detected and can be a gold standard test for very subtle amounts of bleeding that may be missed on a CT scan. So that's another test. And if you do have a third nerve palsy and look for an aneurysm, an angiogram or a CT angiogram or an MR angiogram with MRI can look for that aneurysm. So I've already alluded to what are the causes of subarachnoid hemorrhage. Well, the most important and the most common cause are brain aneurysms. They run in those blood vessels and within the subarachnoid space, rupture suddenly in otherwise healthy people often with high blood pressure or smoking. But there are other causes. This includes other vascular malformations, AVMs or arteriovenous malformations, venous fistulas, and sometimes other blood vessel problems. And if there's a pituitary tumor and it suddenly bleeds, that bleeding, because the pituitary is adjacent to the subarachnoid space, can also cause subarachnoid hemorrhage. But especially because the pituitary is in a location near the optic nerve and the third nerve, you'll also see multiple cranial nerve palsies. You might see a sixth nerve palsy, you may see visual loss, and you may see endocrine disturbances, such as loss of steroid hormones or thyroid hormone. So pituitary apoplexy or sudden hemorrhage of the pituitary is something to look for in subarachnoid hemorrhage patients. And then finally, sometimes you see bleeding that's fairly subtle on a CT scan or MRI scan. There's bleeding just in a few areas of the subarachnoid space, what we call the sulci or a convexity bleed. This is a bleed in the convexity of the skull, of the brain. And this is usually of different causes. This can be due to amyloid in elderly people who have little vasculopathy due to amyloid deposition. In younger people, it can be due to something called reversible vasoconstriction syndrome, often associated with drugs or medications. Also in the setting of eclampsia after pregnancy, this can happen. And sometimes in the setting of trauma or venous occlusion or venous blood clots. So what are the common locations of brain aneurysms? Well, I think if we understand and visualize the circle of Willis and understand that aneurysms occur, as you see in this pathological specimen, at the branching points of the blood vessels, you can get a sense of where these aneurysms typically occur. So if we try to draw the blood vessels, if we draw the internal carotid artery coming up in the neck up to your brain, and then the internal carotid artery divides into the middle cerebral artery, and I'll draw this on one side, the anterior cerebral artery. And then also here, in the back of the brain, there's the basilar artery, which then divides off into the posterior cerebral arteries. And there's also some cerebellar arteries here, which I'll come to. But there's a very important artery that links the anterior circulation to the posterior circulation. This is the anterior, the ICA, and the posterior is from the basilar, which supplies the cerebellum and the back of the brain. And that's what I mentioned before, the posterior communicating artery. And that's where those aneurysms that cause third nerve palsy occur, is at the branching point of the ICA, which is going up into the MCA here. Just before it reaches there, it comes off this blood vessel, and that's where the PCOM aneurysm occurs. Also, the MCA branches into two, and so you can have aneurysms at the branch point of the MCA. The other point where you see a branch is the top of the basilar, and you can get an aneurysm there as it branches off because there's pressure on the wall of the blood vessel over time with high blood pressure, aging, genetics. So you have internal carotid or PCOM aneurysms, MCA aneurysms, basilar aneurysms, sometimes pica, which is this cerebellar artery. But perhaps the most common aneurysm is actually on a blood vessel that connects the two sides, the anterior communicating. We have the posterior communicating. And so here, at that little branch or that little branch, you can have a very common aneurysm called the anterior communicating. So many people have small aneurysms. Probably up to 3% of the population have aneurysms, but thankfully less will have a rupture of an aneurysm. And when you do see subarachnoid hemorrhage, you have to do angiography to assess all these blood vessels. So it has to be what's called a 4-vessel angiography, where you inject both vertebral arteries in the neck, both carotid arteries in the neck, and then only you can see all these blood vessels and say, do you see an aneurysm that caused that bleed? So having drawn that, you can now see in this image a cartoon display of some of those aneurysms. And you see aneurysms in the middle cerebral artery, down here in the basilar, up there in the ACOM. So this just shows you where these aneurysms can occur as we drew out. So then when we have a patient diagnosed with subarachnoid hemorrhage, what are the priorities? Well, the first priority is finding out what is the cause and preventing any more bleeding. So what are we worried about? So rebleeding is number one. We want to prevent more bleeding because we know that if a patient has more bleeding, that can be fatal. In fact, half of people who have rebleeding die. And so finding the aneurysm and treating the aneurysm, and this is most acute in the first day. So that first 24 hours, even the first few hours is key. Most of the rebleeding occurs within a few hours. And then there's hydrocephalus. Hydrocephalus means buildup of the fluid within the ventricles of the brain. That's because the blood is blocking the normal flow of spinal fluid because the blood is in the spinal fluid. And so it's important to look on your CT scan for enlargement of the ventricles. If the patient has headache, vomiting, signs of increased intracranial pressure, placement of a ventriculostomy drain to drain out that fluid is necessary and can be life-saving. And the other thing we'll talk about is the cardiorespiratory status. Again, subarachnoid hemorrhage affects not just the brain, but also the body through the severe acute injury that then triggers a cascade of events that affect the heart and the lungs and even the kidneys. So you need to pay attention to how the heart is doing, the blood pressure, and monitor for arrhythmias. Then, as we'll talk about, this can trigger cerebral edema, which is brain swelling, in the days after. So there's early priorities in day one, rebleeding, hydrocephalus, ABCs, and then there's, over the first few days, brain swelling, and then seizures can occur either at the time of the bleeding or any time in the first few days, and even later. And then, as you work up the etiology, treat the aneurysm, and then in a delayed fashion, as we'll talk about, several days later, a patient who may be doing well can have delayed complications, and that's a delayed phase, so-called delayed brain ischemia or delayed cerebral ischemia. The other thing you can tell in the CT scan is one, hydrocephalus, but also how diffuse is the bleeding. Here you see a CT scan. There's blood, which is in white, throughout the base of the brain, the subarachnoid space. Here around the brainstem, the little Mickey Mouse ears are the midbrain, and there's blood all around there. But there's a lot of blood coming up in the middle of the brain here, and a thick blood clot sitting right here. And that's a clue that the aneurysm may be located somewhere there. That's why the bleeding is thickest in that area. And so when we do an angiogram, which is shoot and dye into the blood vessels, as I mentioned, to look at those different sources, you might suspect this could be an aneurysm of the anterior arteries or the anterior communicating artery that I drew earlier. And so here you see the internal carotid artery coming up as I try to draw. The MCA goes laterally towards the outside of the skull, and then the ACA comes medially, and right where it branches before it goes up to the second part, that little branch point where it mixes to the other side is an aneurysm, and there you see a brain aneurysm that needs to be treated. So there's two ways to treat brain aneurysms. One is through surgery, which is a little more invasive, through clipping, and the other one is through coiling, which is an endovascular approach. There are some cases when surgery may be better, and some cases where endovascular approach may be better. So what are the advantages of surgery? So surgery is more invasive, but more immediate. It generally involves a clip being placed across the aneurysm. You see that there. And so you have a large aneurysm in this next image. And then you see a clip, which is a little bit hard to see, but it's right up here, going this way. And it's basically the aneurysm is gone. So clipping is invasive, but immediate, and very durable. If the clip is placed properly, it usually will last a lifetime. The other downsides of surgery are risk of sometimes blocking another blood vessel if the clip is blocking, because as you see, there's a lot of branches there. And if while you're clipping the ACOM, you cut off one of the anterior cerebral arteries, you might get a stroke. The other thing is the higher risk of seizures and higher risk of bleeding in the procedure. That you might, as you're clipping the aneurysm or poking it around, it might start to bleed. However, the advantage of surgery is that if it does bleed, you're right there, the surgeon is there and is able to treat it and stop the bleeding. The other advantage is while you're in the brain, if there's a blood clot, you can sometimes remove it or drain it, and that can also be helpful. What about coiling? Well, coiling is putting coils, which are detachable metal, inside the aneurysm, and that causes the aneurysm to clot off and then won't have a risk of bleeding. And so here you see a large basilar aneurysm at the top of the basilar. This is the basilar artery coming up. And here you see a number of coils are put inside, as you can see better over here, and it's filling up the aneurysm and treating it. Now, that is not as immediate. It can take hours to days, although usually the effect is pretty quick in terms of the rupture risk. And the success rate is lower than clipping. Clipping has a 95% success rate. Coiling might be 90%. Now, newer technologies are improving that for aneurysms which are a little more wide-necked or have a different geometry. There's new ways to treat them with stents and coils, but still the success rate is not as high, and the aneurysm can recur if the clot kind of changes over time. A little bit of an aneurysm can grow, and it may need to be retreated. So the durability in young patients is not as high for coiling. Now, it's much less invasive, low rate of seizures. There is some risk of stroke, but not because you necessarily blocked up a blood vessel, but from blood clots forming as you're doing the procedure inside the brain with metal. The other complication, it's much less invasive, but you can have bleeding in the groin, and you can have stroke. And if you have a rupture, if you accidentally poke through the aneurysm, there's no way you can stop the bleeding. It may stop on its own, but it can be more severe. While in surgery, you may bleed, but you're right there, and the surgeon can treat it. And this just shows an example of a stent where you can put a stent across the artery, and that allows you for those coils to stay inside the aneurysm and not kind of float out. So there's a lot of new techniques for treating aneurysms. And so that was the pros and cons, that we have surgery that's more durable, long-lasting, but has risks up front, and coiling or endovascular, which is less invasive, but less durable, may need retreatment. But trials have shown in patients who are equally amenable to both, healthy otherwise, the surgery is possible, but coiling is also possible. So some aneurysms are not amenable to both. But if they are, generally coiling is preferred, and the outcomes of patients in the hospital and even out to a year will be better than having to go through surgery. What else can happen when there's blood and bleeding and high intracranial pressure in the brain with a subarachnoid hemorrhage? Well, one is it can affect the heart, as I mentioned. How does it affect the heart? It can affect the heart rhythm. It can affect the EKG, cause arrhythmias. And so here you see an example of an EKG, and you see diffuse T wave changes in some of these leads. These T waves are inverted, and they should be pointing upward. And these are typical changes of the brain as affecting the heart, so inverted T waves. What you can also see is prolongation of the QT interval, which is the interval between the QRS and the T wave. If that's prolonged, that's important to recognize because it can put the person at risk for arrhythmias, especially torsade, which is a very potentially fatal arrhythmia. The other thing you may see, and here you see on the EKG resolution of those changes. So within a day or two, the heart recovers. You also may see a transient rise in the enzymes like troponin. And finally, and perhaps more importantly, sometimes that heart can be stunned. And sometimes it's stunned by that excess sympathetic discharge that is occurring, and that can cause dysfunction of the heart pumping. And it can be in a unique pattern called Takotsubo, or the octopus pattern, where basically you have a heart at rest, and then systole on the right, you see it contracting, and only the top part of the heart, or what's called a base, which is over here with the arrow, is contracting, and the apex, which is that octopus part, is staying wide open because it's not working. So that's a focal Takotsubo cardiomyopathy, which often occurs, especially in severe subarachnoid hemorrhage. Now that's reversible over time, but it is important to be aware of because you may need to provide cardiac support to those patients. As I said, that early injury affects the heart, sometimes can affect the lungs with pulmonary edema, affects hydrocephalus, rebleeding, but the other thing to worry about is early brain injury. And early brain injury means a cascade of things that happen after the aneurysm ruptures. As I said, that involves high intracranial pressure because there's basically arterial blood filling that area, so very high pressure. That causes the blood flow in the brain to come down, and that will trigger a whole cascade of injury mechanisms. This includes breakdown, importantly, of the blood-brain barrier, and that can cause swelling in the brain because if the blood-brain barrier is broken down, the brain can begin to swell. And we actually now realize that this early injury, mainly shown by brain swelling, high intracranial pressure, is as important as what I'll talk about later with vasospasm and delayed complications. So we need to pay more attention to the early brain swelling, and this is what it looks like. So here you see two examples of CT scans a few days after bleeding, and what you notice on the upper slice of the brain, there's no sulci. Those gaps in the brain, the folds of the brain are totally swollen. So that's what the CT scan will look like. And even at the base of the brain, down here, for example, the normal space around the brainstem is effaced. That's a sign of increased intracranial pressure. So that's early brain injury. The other thing to mention is hyponatremia. This commonly happens in the first few days up to a week after bleeding. Again, it's affecting the kidneys, affecting the regulation of the hormones, and hyponatremia, or low sodium, occurs in almost half patients to some degree, often in a few days later as those cascade of events and hormones change. And it can be for different causes. And so how do we know the cause? Well, there's two possibilities when someone has brain injury for why they may have low sodium. That can be, number one, because of something called SIADH. We put that here, SIADH, which means syndrome of inappropriate ADH or antidiuretic hormone. So there's too much ADH being released by the brain in response to injury. The other disorder is cerebral salt wasting, which is release by the brain of natriuretic peptides, which basically affect your kidney and make you release salt. And so these are both cause low sodium. One, fundamentally, this is more ADH. These are more salt wasting or salt excretion. And what does it cause? Well, this one causes water retention because it's antidiuretic, and this causes salt loss. So how do we diagnose them? Well, fundamentally, this is about volume status. So we look at volume status of the patient, which is sometimes hard to tell. In this, it'll be normal or increased because you're retaining water. You're not losing water, you're not losing salt. Here, you're losing salt, which is going to make you very dehydrated, and the volume will be down or dry. So that's the fundamental way to separate out SIADH and salt wasting. What else may you see? Well, if someone has salt wasting, they may have a high hematocrit, which is basically a concentration of their blood. They may have a high kidney function because they're dehydrated, and they may have a high heart rate. So these are clues for salt wasting. And these, you won't have any of those. One thing that's commonly assessed is, well, can we check in the urine? Maybe because in salt wasting, the urine sodium will be high because you're losing salt. Well, unfortunately, also in SIADH, the urine sodium will be elevated. So this is not going to be a good way to differentiate. Ultimately, what you need to do is look at both and look at the volume status and say, do you see any signs of salt wasting? If you do, the treatment is going to be giving salt. And how do we give salt? Usually through IV saline of some type, whether it's normal saline or hypertonic saline. How do we treat salt wasting? We want to minimize that water that's being retained, so we give them less water. But in fact, we don't want to do that, as I'll talk about, because the volume status of the brain is very important after injury. When the brain is injured, we have to maintain blood flow, maintain volume. And so in fact, if you're suspicious for SIADH, and in the past, in the 1980s, they would say you can't have any water, we can't give you IV fluids because we think SIADH is a major problem. What that then leads to is more strokes. As I'll talk about, strokes are what we worry about in the delayed ischemia phase. And so what the recommendation is, because of this risk, is to treat everyone as if they have salt wasting. So fundamentally, this is important to recognize, important to know, but you're going to presume most patients, and this is just with subarachnoid hemorrhage, have some element, unless you're extremely confident in your volume assessment, that there may be a little bit of salt wasting. I'm going to give them salt and saline and not restrict their water. Now what you can do is restrict just PO water, meaning you don't want them to drink lots of water and juice, but you don't want to stop their IV fluids because you want to keep the hydration up. So fundamentally, you have to avoid fluid restriction, give hypertonic saline, and then, because this is a salt wasting problem, sometimes you can block that with steroids. Mineralocorticoids or steroids like fludrocortisone block the salt. So if the sodium is still going down, you're worried about low volume, you can give mineralocorticoids. So the last part I'd like to talk about is delayed vascular events, which is a lack of blood flow, lack of oxygen to the brain that can cause strokes after subarachnoid hemorrhage. And it's important to recognize that there's two things going on. There's cerebral vasospasm, that's a narrowing of the blood vessels. It's very common. It's reversible, but it does occur around 1 week. So in a person who's doing well, they may develop narrowing of the blood vessels. Slightly different from that is the development of symptoms. That's stroke-like symptoms that are delayed, called delayed ischemic deficits. And now this is not the same as vasospasm. Only half the people who get vasospasm get symptoms. And then the problem that we're really trying to avoid is cerebral ischemia that's delayed, or DCI, and that's the risk of stroke or actually having a stroke on a CAT scan or MRI. And it's important to recognize that vasospasm doesn't have to be present to have a stroke. So often they go together, but we don't require vasospasm to be present. And that's because smaller blood vessels may be involved that are not shown on an angiogram, and there may be other changes such as lack of blood volume or autoregulation, which is the control of blood pressure. So it's very important to monitor blood pressure and blood volume. And this is an example of before vasospasm on day 1, the blood vessels are relatively normal. And then on day 7, you see a narrowing by the arrows where the blood vessels become narrowed, and that can impair the blood flow. What are the risk factors for this? Well, more blood. So if you have thicker blood, more blood within the brain after the bleed. Also, younger people at higher risk. Other vascular risk factors like smoking or cocaine use, and more inflammation or SIRS. If there's more going on, it triggers more of this blood vessel changes. How do we treat it and prevent it? Well, every patient should have nimodipine. It's a standard drug given to subarachnoid hemorrhage patients for 21 days. We maintain that volume status that we just talked about, maintain the sodium, allow the blood pressure to be relatively high as long as the aneurysm is treated. Before the aneurysm is treated, we keep the blood pressure down to prevent bleeding. After it's treated, we want it to run relatively high. And if you can remove the blood that's in the brain. Now, just right off the press, very recently there was a study showing that lumbar drains, which is a drain placed in the back to drain that blood off, actually improved outcomes in patients with subarachnoid hemorrhage, specifically reduced the rate of stroke. So this is the first study to show that blood removal can actually help patients, and I encourage you to read it. How do we look for this kind of stroke? One, most importantly, is what symptoms do people have? Do they develop symptoms? We can do an angiography to look for that narrowing. We can do CT angiography or transcranial Doppler that has a little bit lower sensitivity. We can do CT perfusion, looking for areas that don't have blood flow. And sometimes we can even do EEG to look for lack of the brain function as it loses blood flow. And then finally, how do we manage this ischemia? Well, anyone who has symptoms should be treated aggressively to prevent a stroke. First, you will have to rule out mimics, things that might look like a stroke, like a seizure. Patient has a fever or low sodium, may act confused or sleepy. We don't necessarily treat asymptomatic vasospasm. So someone who has narrowing of the blood vessels but is doing well doesn't need all kinds of aggressive treatment. But if you do have symptoms, you need to treat that aggressively with fluids by raising the blood pressure with the goal of raising blood flow to the brain and seeing if the patient responds. And if they don't improve, do angiography. And that's not only to diagnose vasospasm, but to treat it. In the angiography, the blood vessels can be dilated either by medications, vasodilators, or by a balloon to open up the vasospasm. And then finally, if that's not working, there's even other treatments like milrinone, which increases heart function, nicardipine inside the brain, which is a vasodilator, or giving blood because blood provides more oxygen. And we know that oxygen delivery to the brain is what causes stroke. And then there's risk to that treatment. So be careful when you're raising blood pressure, giving fluids. Make sure you monitor for things like pulmonary edema, arrhythmias from the medications, and it also can make the brain worse. So you have to monitor for hemorrhage, or even, as we reported here in this paper, cases of press or brain swelling in the back of the brain due to high blood pressure. So always pay attention to that. And so I'd like to finish by saying subarachnoid hemorrhage encompasses a combination of body injury, brain injury, and different phases from the early priorities to delayed cerebral ischemia, and is really a disease that helps you understand how the brain responds to injury. Thank you.